Oh, we're up to 20 people, so should we make a start?
Yeah, that's quick, isn't it? Let's go. Yeah. Let's get going. So, episode 35. Delighted to welcome Mr. Ryan McCallum, podiatric surgeon from London. Privately works on Harley Street, as I know, because I'm sending in people. But remind me where you work in your NHS post, West Mid and
Yeah, so I'm at West Middlesex Hospital in West London, and I divide the other half of the week in Hackney in East London, so Homerton Hospital. Perfect. And then privately, as you said, Harley Street.
Excellent. So thanks so much for your time. Appreciate it. I know you're busy. You've come off the back of I've walked off the golf course to do this.
I can tell.
You've come off the back of a 15-hour clinic. That just shows that, the work ethic differences between the two of us. But yeah, we do appreciate your time, and the topic looks like it's a pretty one that's generated a lot of interest, and that is X-rays. We titled it X-ray interpretation, but actually that's just going to be a small part of it, because a lot of the questions that came in were more about the kind of lead up to X-rays. So I've organised them into what I think is a reasonable, logical order, and we'll just run through them. And obviously, as questions come in, if questions come in, Craig will pitch in when appropriate. So we thought we'd kick off. Obviously, I know your answer here will be with respect to the UK, and Craig can let us know about Australia. But with respect to podiatrists, not podiatric surgeons, but podiatrists, and X-ray requesting X-ray or ordering, how much do you think we're utilising this? And if so, do you think it's not enough or too much?
I suppose it depends on people's general area of practice. I mean, I think those who are working within diabetes probably should be using it a reasonable amount, or at least be exposed to other people. So working in an MDT. Certainly in our diabetic MDT, there's a massive part of it is radiology. So maybe not necessarily directly using it, but they should certainly be exposed. I'm not entirely sure about MSK. I mean, you would probably be able to tell me more than I would know, but I think it's possibly underutilized, because there are many things that can be taken from X-rays that will certainly guide towards certain diagnoses. We got the right diagnoses, then a treatment option is always easier to pick, isn't it?
Yeah, absolutely. A really common question that came in off the back of this is how do we get started as podiatrists? How do we get started in the whole world of X-ray? We don't have to go into the real depth of things like Emmer, but clearly we can't just start ordering. There's a process. There's some training we have to do. You briefly sort of summarise it for us.
Yeah, well, again, it'll be easier for some people more than others, depending on your setting of where you work. Certainly, Emmer is mandatory. If you're going to start requesting X-rays, then you have to have an Emmer certificate. I know some of the MSc programs have included that. The surgical ones, anyway, have included that within their programs. Hospitals will run Emmer courses, so we have an intern that works with us, and he was able to run through his Emmer training through in-house. So I think people can always approach their local trust, their local hospitals, and just ask the radiology departments, do you run an Emmer program? Because hospitals are always happy to make money, and if they're charging £100 or £150, I have no idea what it costs. But hospitals, I'm sure, will be more than happy to have external people coming in and attempt their courses, because as I said, it makes them money. Once you have an Emmer certificate, then I guess it's a case of building relationships and building bridges towards either a private hospital who is able to offer the service, or even NHS trusts. If you liaise with them and you prove that you've got their certification, there's no reason why they shouldn't let you use their services, as long as you're using it responsibly.
Yeah, and talk to me quickly about Emmer. Really quickly, is it you got your certification, you're good to go forever? Or is it like a life support where there's an annual sort of update? How does that work, sort of long term?
It's been so long since I did my Emmer, but I think, to my knowledge, you've got it once, and that's it. You've got it. I always took Emmer as more of a, I suppose, proof that you appreciate the potential hazards of diagnostic imaging, or essentially using the services appropriately. I don't think it's anything that you need to update, and if you do, I could find myself in a bit of hot water.
Yeah. I might have stitched you up there by accident.
Yeah, I hope you haven't.
So we decide we're gonna get stuck into this, whether it be MSK, diabetes. We go through the appropriate certification at Emmer. We start a day in clinic, and we've got patients that are coming in.
Yeah.
What's our process of clinical reasoning? What sort of things are coming into mind when we're thinking about requesting an X-ray? I guess when is requesting an X-ray appropriate? Whether we're talking pathologies, particular pathologies, or certain timelines of when someone presents with a 2-day-old problem versus a 2-year-old problem.
Yeah. Well, obviously, my practice is probably a bit different to others in that I'm in purely surgical practice, so I use them an awful lot. There wouldn't be too many patients that I would see who wouldn't get an X-ray, but as far as indications and when you would request them, I think it has to be when it's going to have the potential to change your management of the patient. So, as I mentioned earlier, starting off with a clear diagnosis is obviously critical regardless of the area of specialty you work in. So, I suppose if there's any uncertainty over a diagnosis, an X-ray is not a bad place to start. I mean, there will be obviously pathologies which X-ray is totally useless for, soft tissue pathologies in particular. But if there are queries over, as for an example, a lesser MTP joint pain as opposed to a potential neuroma, there are certainly clues that you'll pick up from an X-ray, potential clues that will guide you one way or the other. It's readily available. It's very, very cheap. And I certainly use it a lot. And not every patient I X-ray goes for surgery, so I would use it primarily to help establish a diagnosis. But what it's not really used for, is not indicated for, is just widespread. Well, I'll just get an X-ray and see what's there. That's not really helpful.
Yeah, makes sense. There was a meme that went around a while ago. I think it was of Prince William, a photo of him taken from 2 angles. And he had his hand in the air, and from one angle it looked a bit rude, and from the other, and it didn't. And it sort of spread across the world of radiology as the sort of stressing the importance of 2 views. Do we always take 2 views for every pathology? Are there 2? Do you decide on the views per pathology? What's the thought process there?
Yeah, I mean, 2 views is minimum of 2 views is absolutely essential. And I explain to patients and students that, you know, 1 X-ray image is no different to looking at a loaf of bread from one side. You've no idea what's going on anywhere else, whether there's mold on the other side or whether it's, you know, or whatever. So from my point of view, I can't think of too many pathologies that DP, so a dorsal plantar view, an X-ray taken from the top of the foot, and a lateral view, those were going to give you an idea of the vast majority of pathologies. Strangely enough, you see an awful lot of, so, you know, if a GP requests X-rays, for example, they're trying to be helpful, they'll send a patient for X-rays before they see you. It'll be a non-weight-bearing DP and an oblique view. And that does't really tell me a great deal, to be quite frank. So DP and lateral stand views are almost always the standard X-rays that I'll take.
Always weight bearing?
The only time I don't do weight bearing is if it's post-operative patient and I don't want them to put the foot to the floor. If it's my query osteomyelitis, it doesn't really matter a huge amount. You wouldn't necessarily want them standing on it also. The radiologists won't, or radiographers won't let them stand on an X-ray plate if they've got an open wound. But from my point of view, when I'm taking X-rays, it's fractures. So another indication for non-weight bearing would be a fracture. But from my point of view, I'm really quite concerned about alignment, and I'll use X-rays a lot for alignment. And alignment tells me an awful lot about what's going on with the foot and give an indication to one pathology over another. And if it's non-weight bearing, you can't tell anything about the alignment from a non-weight bearing X-ray. So there's a very, very small indication for requesting a non-weight bearing X-ray.
Yeah, I remember seeing someone not that long ago who ended up having a fairly nasty Lisfranc injury, and it was missed on X-ray because they'd done it non-weight bearing. It was one of the pathologies that, you know, I think they went to A&E. They were worried it was a fracture, so probably by your reasoning there, did the right thing by a non-weight bearing X-ray. Yeah. Didn't pick anything up, and then it's gone missed because it wasn't a weight bearing as it needs to be. Are there any other sort of pathologies where weight bearing would be really key, a bit like a Lisfranc, or doing weight?
Well, certainly for pre-op planning, it's absolutely essential. And as I gave you an example of generally hallux valgus, if a GP sends a patient for a non-weight bearing X-ray and they've got hallux valgus, you almost always see a degree of metatarsus adductus, and that can vastly change how you approach the foot. Then you send them off, get a weight bearing X-ray, and it looks completely different. So certainly pre-op planning, almost always essential that you have weight bearing, and as a true weight bearing as you can get it.
Yeah. So DP and lateral, easily the two most common requested. The oblique, does it have a place? Is there anything that you?
Yeah, oblique's very good for helping you identify a fracture, because if you're looking at, for example, a metatarsal fracture, it's highly unlikely you're going to see anything significant on a lateral view. And a DP view, as we mentioned, you need 2 views to look at any particular pathology. So for a fracture, osteomyelitis, where you're looking for a periosteal reaction, where again on a lateral view, you'll probably not see an awful lot because of superimposition. So fractures and osteomyelitis, I can't think of too many others that I would routinely request an oblique view for.
Yeah. I seem to remember a funky view for the sesamoids. Is it called axial? I can't quite remember.
Sorry, Ian, you've gone quiet. Ian, I can't hear you.
Can you hear me now? Am I okay? Am I better?
Yeah. I think. I don't know. Can you hear him right? Can you hear me, Ryan?
I can hear you, Craig. Yeah.
Okay. So Ian was just asking about what he called the funky view for sesamoids, the axial view.
Yeah. I mean, again, there are other views. There are views that I would call fairly unusual. An axial sesamoid view is obviously useful if you're looking for first MTP joint pain and you query a sesamoid fracture. You don't actually always see it, especially if it's fragmented. You'll not always see it on a DP view. Lateral, you'll see nothing. So an axial view for that is fairly useful. There are other, I say, very rare ones you might take. A Harrison-Beath view or the ski jumper view if you're maybe looking for a possible subtalar joint coalition. But obviously, could probably count in one hand the amount of times I'd request those in the space of 6 months.
Can you hear me now? Am I back?
I can, yeah.
Great. Sorry, no idea what happened there. While we've touched on things about pre-operative X-rays, there was a question that came in about the lines and the angles that you sort of look for. Two questions, two parts to this question. Firstly, are there specific ones you're doing on an almost regular basis? But the second question was, would you ever do lines and angles in the non-surgical setting if you were looking at MSK pathology, for example? Yeah.
So if probably just to go back a little bit before you're looking at angles and dangles, there is a systematic way that you approach looking at any X-ray, and most people probably have heard the ABCs. So if I could just put up a picture here of an X-ray which has quite a few things going on in it, if I just bear with me 1 second here.
Everyone loves a picture. This is perfect. Except the ones listening on the podcast, of course.
Yeah. Well, they can always go back and watch this later on, I suppose. So, if I just make, I think, can you see this? Is that visible now?
Yeah, perfect.
That's fine.
Okay, so I'll just make it a little bit bigger to take up the full screen. So if you look at this here X-ray, for an example, there's a lot going on here. And if you're trying to interpret this, it's a case of, well, where do I start? Obviously, there is the first met's in an unusual position. It's an unusual shape. There's a fracture in the third metatarsal. There's, the toes aren't necessarily rectus. So where do you start interpreting or trying to take any useful information from this? And so if you take a systematic approach to looking at an X-ray, it becomes much easier to make sure that you don't miss anything. So rather than getting angles, which is of course related to the alignment, it's the first thing you'll do. I would look certainly at, so just the ABCs, A being alignment, for those who aren't familiar with this. B is referred to as bones or bone density, which a lot of people assume that B just means bone density. But if you just take bone density, you could certainly lose or miss some valuable information. C is cartilage or joints, and S is soft tissue. So this is just a slide I've taken from an old lecture I gave. And obviously, the alignment relates to the position. And obviously, it depends on who you're talking to, but it's really important to keep things simple. So if I speak to a colleague or I ask one of the trainees, tell me about this X-ray, I don't expect them to say off the cuff, oh, this has an intermetatarsal angle of 18 degrees or whatever. I expect them to say that the first metatarsal is deviated in a medial fashion away from the second metatarsal or whatever. So keeping things quite simple. But then you can knuckle down into angles if you really want. But what I think is probably more important is just looking at relationships of one bone relative to another. And this slide here shows on the left side a relatively normal foot. and on the right side is a pathological pediatric flat foot. So if you wanted to look at angles, well, yeah, you can measure them, but I personally don't. What I look for is relationships. So I'll look at the angulation or the direction that the talus points in. And in a normal foot, it should be relatively similar to the direction that the first metatarsal points in. And obviously in a flat foot, because we know the talus moves medially and plantar flexes. So I'll look at the direction of the talus rather than actually measure the angle of the first metatarsal relative to the talus. Whilst it's an angle, the numbers don't really help me a great deal. And then I'll look at the relationship, for example, of the calcaneus and the cuboid. You could measure this, you're looking for your forefoot abduction. So there are more relationships that I'll look at rather than angles. And then in a lateral view, there are similar things. So you look at Neary's line and, again, positional relationships of one thing to another. Where it does come useful and where you could measure things with regards to, where you could look at things from an MSK point of view, and I go back to the sort of forefoot discomfort, whether it's an MTP joint pathology or a neuroma. One of the things that I measure a lot of, and anyone who has any forefoot discomfort, I'll look at the metatarsal parabola angle. So this, essentially, you're drawing a line from the central aspect of the first metatarsal head to the central aspect of the second, and then from the central aspect of the fifth metatarsal head up to the second. And you're looking, on average, for an angle of about 142. And in these cases where the angle is less than 142, it's a fairly high or strong indication that this person is predisposed to overloading the lesser metatarsal phalangeal joints. So if I saw a patient, for example, with a short first metatarsal, and I measured the angle and it was 133, I'd be highly suggestive that this was probably a second MTP joint pain rather than a, say, 2-3 space neuroma. Does that make sense?
Yeah, yeah, it does. Interesting. That's not an angle I was familiar with, actually. You referred me a patient about 3 weeks ago, and you mentioned that in your letter, and I was too embarrassed to ask you what it meant. So I'm glad you touched on it.
Oh, really? Oh, sure.
Now you just embarrassed yourself publicly.
Yeah.
So I'll just for those who aren't familiar, you know, this is the metatarsal parabola angle here.
Ah, perfect.
And I use that a lot for any forefoot discomfort, especially trying to differentiate where it's a query between a 2-3 space neuroma or second MTP joint synovitis or capsulitis.
And that normal, Ryan, that 142 for a suggestion of normal, is that from a big sort of asymptomatic cohort? Is it how have they sort of landed on that quite specific number there?
Do you know what? I have absolutely no idea. I remember it being 142, and I can't remember where I remember it from. But it's a reliable one for me. And I mean, I think it's these X-ray and the angles are indications. They're not set in stone, because obviously the length of the metatarsals, because you're looking at a 2D image, is going to change if it's dorsiflexed or plantarflexed, because it will look shorter if it's one way or the other. So it's an indication rather than this is definitely overloading of this joint or it's definitely not a joint problem. So whilst I picked 142, it's a ballpark figure, really.
Yeah. Okay. Perfect. So going back to our sort of timeline of people saying, right, we're going to start utilising this, we're going to get Emmer certified, we're going to decide when X-rays are appropriate with regard to pathologies, we're going to make sure we get at least 2 views and decide on weight-bearing, non-weight-bearing. The most important thing, from what I'm taking from this, is the X-ray film comes back to you, and the first thing you do, whether you've been doing this 1 year or 10 years, is your ABCDs. Is that fair?
Yeah. It's certainly. I mean, I don't do it because I look at X-rays all day long, and I think like anything else, if you know what's normal or relatively normal, it's very easy then to see something that's abnormal. So I think when you first start off doing these, it's a great way to make sure you don't miss anything, and then you really fine tune. And sometimes it's the small things that make big differences. So if you're really systematic about how you approach these in your interpretation, it's great practice for then recognizing what's normal or abnormal, and then it just becomes easier. It becomes second nature. So I'll look at an X-ray and I'll recognize a short first metatarsal straight away, or a degree of metaductus or whatever, talar declination. I don't need to measure them because I see it all day and I know what's abnormal. But it's like anything else. It's not difficult. It's just a case of making yourself very familiar with it, looking at as many as you possibly can, and then you get an appreciation for the differences.
Yeah. But
I mean, all of our trainees are made to go through ABCs from the word go. That's it has to be the best way of making sure that you're picking up everything that you need to pick up on.
Yeah, yeah, makes sense. Good to have a system. Craig, are there any questions came in on that?
Well, no, the only question came in was about the Emmer Regulations, and someone just commented, what are they? So I've just actually, I didn't know what they are either, because they're obviously specific to the UK, but I did manage to find the regulations. So it was Emmer was what you're referring to, and there does seem to be quite a few courses around. I just found this one here available for allied health professionals to do, to become familiar with them. So there seems to be plenty there.
Yeah, and the guidelines are readily available online as well. Google Emmer, you'll get the first page you come up on will be the government document of what Emmer is. So it's very easy to find the information.
Yeah, I've posted a link in the comments to the websites I just showed.
So Craig, quick diver into Australia, because I know we have Australian listeners as well. Not always live because it's so early where you are, but we know they listen later.
Well, actually, there's quite a few on already. I noticed from Australia. Arthur's there.
Isn't it like half past 5 where you are?
5:30 in the morning.
Crazy. Arthur's the only one I know who sleeps less than you, actually. How does the stuff we've talked about differ logistically and in Australia?
No, well, I think it's much more integrated in the undergraduate program, so it's just a pretty much normal accepted part of everyone's practice. Some, obviously, the pod surgeons here are going to be using it like Ryan is. Those doing a lot of musculoskeletal are going to be using it. Others are going to be using it less, but it's not something you have to get separately sort of certified or a course in. It's just integrated in the undergraduate program. So it's
really, so new grads can just get going on it and start requesting them.
Start referring,
okay.
Whereas the situation in New Zealand is they can actually own their own machines, or they used to be able to. I think they still can. I'm not sure how many do own them now. And obviously in the US, they X-ray everyone. Or next to everyone. And I think we can debate the issues around that, but this is not really the place to do it.
No, absolutely. We had another question actually, which came in about the logistics of this in private practice, because we know, we know in the UK we've got more people in private practice than ever before. I don't know the numbers, but even the people that are working in the health service are often doing some private practice work as well. So logistically, what's the best way to describe how that works for people, Ryan? I mean, do you need to? I know we're lucky in London. We have several imaging centres that we can just send people to, and they pay, and then the report comes back to us. Is that the case across the country? I mean, you've trained across the country and things.
To be honest, I wouldn't entirely know, because I've only ever, since I left Ireland, I've only ever lived in London. But there are private hospitals all over the place, and they're only too happy to take money for anything they can get. So I would be astounded if anyone had Emmer certification and they were refused an X-ray service from a private. I'd say they'd be only too happy to take referrals. The only thing is that, it's pointless unless they're going to do it the way you want it done. So if a private hospital, we'll do X-rays, but we're only going to do non-weight-bearing X-rays. Well, that's pointless. So if you're going to get them, you need to make sure you're getting the right ones. But as I just approach these hospitals, approach the centres, imaging centres, I say only too happy to make money off patients having diagnostic imaging.
And do they just send the plain films back to you, or do you get the radiologist often reports on them as well? How much weight do you place on? I mean, I'm guessing you as a surgeon will always look at the films, but is it appropriate to go through this and then just get the report back and go on the report? What do you think about the balance?
I never rely on a report from a radiologist or radiographer for that example, because a lot of them are reported by radiographers. Because the amount of times I say, or I get a report saying, no bony injuries, no soft tissue, evidence of blah, blah, blah. And you get it back, assuming you're going to see a normal X-ray, and it's completely different. They'll miss sesamoid fractures. Basically, if it's not a metatarsal bone that's broken, or a joint that's obliterated with osteoarthritis, they're going to tell you it's relatively normal, and it's not really very helpful. The other thing is, you should be getting the images, looking at them and learning from them. That's the great value of getting the pictures. Patients are normally given the pictures on a CD or DVD, I don't know what it's called these days, and the report will normally come in writing. But I guess it depends on where you work. Where I work, the X-ray systems are within the building, so they come onto my computer straight away. But I would always encourage people to get the films, study them, look at them, even try and make a report yourself, and then compare it to the report of the radiographer or the radiologist if you are of the mind that their opinion is worth listening to.
Yeah, it's very rare you're going to get those X-rays that you showed earlier on. It's very rare in a report you're going to get some of those alignment issues reported on.
Yeah, they'll never talk about alignment unless it's helicologist,
and that's so crucial. So you can rely on the report for some nasty looking lesion, but that's those alignment issues are never going to be reported. Yeah,
you're absolutely correct.
So is it fair to say, I mean, obviously if we're referring to surgeons or other specialists, what we often like to do is know them, having met them before, we know that we're roughly on the same page, have a relationship.
Yeah.
Sometimes personal / professional. Is it less important that we have that relationship with the radiology department? Can we just use any, Adnan Nazir's just commented, Nuffield Health do this. So can we just contact our local Nuffield, don't worry about making a relationship first, just get the films back and then look at them ourselves? Or do you think that relationship has any value?
I think it definitely has value. I mean, I speak to my MSK radiologist on I wouldn't say a daily basis, but certainly a weekly basis. Not so much about X-rays, but there are occasionally things that creep up, unusual appearance of a periosteal reaction, or maybe something like a lesion within a bone. I'm thinking, well, I have no idea what this is, and I'll always seek their opinion. So I wouldn't say it's not worthwhile. It depends on how much you intend to tap into their knowledge and experience, but they have very rarely have any idea of foot function. So as Craig said, if you really want to get an idea or an indication as to a particular diagnosis, the alignment is so critical, and they'll not tell you anything about that. I would probably say it's more of value to, build a relationship with a colleague or a podiatric surgeon or anyone who looks at X-rays regularly from a foot point of view, and just ask their opinion. I mean, so you and I could pick up the phone to each other at any stage and say, well, listen, what about this? Or what do you think of this? Or I have no idea what this means. What is that? I think probably someone who appreciates foot function is probably the better person to build a relationship with, but I definitely wouldn't say don't speak to radiologists, because there are times that, despite looking at X-rays day in, day out, I don't have a clue what I'm looking at.
Yeah. Any tips, any quick tips for someone first requesting X-rays with regards to the terminology, the language to use on the request form? Because clearly what you don't say is something like, please X-ray left forefoot. I remember being taught, it's like going into a football stadium and saying, can you take a photo of the F block? You want to give the most information you can. I mean, how deep do you go? Do you give them your queried provisional diagnosis, or how do you sort of actually write on the form?
So X-rays less than ultrasound or MRI, for example, because there's so much to look at, whereas an X-ray, you're looking at a 2D image and it's fairly quick and easy to interpret. So a standard X-ray, for me, I'll say 4 foot, because I'm not relying on the report. Essentially, I just want the image. So I'll say 4 foot pain, or pain in the region of the second MTP joint as the clinical indication. And then in the examinations to be requested, I'll just write DP and lateral standing views, left foot, or axial sesamoid view, or whatever it is you're looking for. So I don't think you need to be too descriptive, because ultimately I'd like to think that if people are requesting X-rays, they're going to want to improve their knowledge on them. So they'll take the pictures and they'll look at them themselves. They're not really relying so much on the report.
Yeah. A question just came in from our friend Sean. Not about your wallet, I promise. It says, Ryan, can you see an insufficiency fracture on a plain X-ray?
Gosh, how often do you see insufficiency fractures in the foot? I can't think the last time I saw one. Probably similar to a stress fracture. You'll often not see it straight away, but you'll see the periosteal reaction a couple of weeks down the line. I'd imagine it'd be probably similar. I can't remember the last time I saw an insufficiency fracture in the foot.
Yeah, I wonder if he doesn't mean stress fracture, but the answer is you can't until it starts healing.
Yeah.
Well, someone actually did. One of the questions was actually, everyone's fairly familiar now that X-ray is no good for a stress fracture, until after the fact. What the timeline on that? 6 weeks gets thrown around fairly routinely. Is that still supported by data?
Data, I'm not too sure. I mean, it depends on which bone it is. So, for example, if it's a second metatarsal, you quite often see a very slight periosteo reaction. I've seen them at 2 weeks.
Yeah.
Calcaneus is a little bit different, maybe a little bit longer, but certainly a metatarsal stress fracture, 2 weeks, you'd see a very subtle periosteal reaction. And if it's in the region where they've got discomfort, you can be pretty sure that it's probably a stress fracture.
Yeah. Another question that's come in, all the exciting ones now. The relationship between heel pain and heel spurs is one, a grey contentious one. I know Craig will enjoy this one. You know, gone are the days, we hope, that everyone that goes to the GP with plantar heel pain gets given an X-ray, but we know that still does go on. Have you noticed any sort of patterns emerge when you've been X-raying calcanei with regard to presence of spurs in the general population, but, you know, versus those with heel pain?
Craig, is that direct? Is that me, Ian, or Craig?
Yeah, that's you. I know that this is just a topic that Craig hates or loves to hate.
Yeah,
I'll bite my tongue.
I mean, gosh, the last time, well, I'll tell you, the last time I looked at an X-ray for heel pain was yesterday. It was a diabetic patient who had a pressure sore, and it was requested because it was painful and it might have been infected. And the guy had a massive beak fracture of his calcaneus, but that's kind of fairly unusual. I mean, your normal run-of-the-mill patient who has heel pain, you go to certainly West Middlesex Hospital with a GP request for an X-ray of a heel, they'll refuse it. But as far as incidental finds of spurs, I see them all the time.
Yeah, actually, Ian, it's interesting. I mean, you obviously know my views on heel spurs and heel pain, but it's kind of interesting with what we've been discussing over the last few years about all the nocebo language. You know, when patients just get so fixated, they've got heel pain, they've had an X-ray, there's a spur there, that's it. You know, and you put that in the context of all the nocebo language we've been talking about so much lately. You still got to roll your eyes that the damage that has done to them in their belief systems, and you know.
Yeah. Here's a question sort of on that line, Ryan. Sometimes when I see a patient in clinic, I have to make most of the role that one of the big decisions I'm often thinking about is whether I think foot orthosis is an appropriate intervention, just because of the demographic I'm seeing. And sometimes I make a decision it's not a sensible thing to do, and that decision has nothing to do with the actual pathology. It could be a great pathology to respond to that kind of intervention. It's often to do with the person, the patient. It's just, that's going to be a terrible idea for various reasons. There are various flags being waved around.
Like some you sent me recently?
Yeah, well, yeah, maybe. Is there a process in your mind with regards to requesting imaging? I guess X-rays, X-ray, that's the topic of this episode. But do you ever think to yourself, okay, this person is going to be, they're going to hack whatever we find on the report, they're going to hang on. This is probably a terrible person to image. Does that ever play on your mind?
I'll tell you what, actually, in those patients, I'll use imaging even more. I'll probably go to MRI because I can say to them, listen, there is nothing there. There's nothing treatable for me. There's nothing I can do for you. Doesn't mean you don't have pain, but there's no treatable pathology that I can help you with. Goodbye. So I would use imaging more in those patients. Certain patients will insist on, I need another X-ray, and ultimately you have to weigh up, well, is it ethical to keep sending patients for X-rays? But we spoke briefly earlier about radiation. I mean, the radiation from a foot X-ray, I think it's something like the equivalent of 1 day of natural background radiation in the environment. So, or smoking one cigarette, I'm not too worried about the radiation of an X-ray, certainly of a foot. I suppose you just got to judge it, don't you?
Yeah.
I mean, the way I've always taught it, I get more radiation flying from Melbourne to Sydney than you do from a foot X-ray. Yeah. But I'm not sure of the wording in the UK regulations, but the wording of the regulations are over here is that you've got to keep it as minimal as possible anyway. So there's an ethical obligation to minimise it, but it's so low anyway. But
yeah.
On that note, ages of your patients, is there a bottom age that you with regard to radiation exposure in children is where my mind is with this. Is there a bottom age that you think we probably shouldn't be exposing these people unless this X-ray is really going to change management?
I think it depends on the pathology, really. I think, I mean, I don't see infants, very rarely I'd see an infant, and many infants have a pathology that you need X-ray for. I would X-ray, I mean, I'd be X-raying because of surgical planning, and ultimately, for the sake of the radiation of one X-ray, I want to get the operation right. I want to get the diagnosis right. I want to pick the right procedure. And I think taking the X-ray in a child is, I think if you have to do it, you have to do it. And the importance of getting it right hugely outweighs the radiation that they're going to get from it.
Yeah, I was trying for a moment to think of the word. It's ALARA, ALARA, as low as reasonably achievable is the.
Yeah, I'd say that.
Is that principle of minimising the dose.
Sean's just added an additional comment, I think, just off the back of his previous question about insufficiency fracture. He was referred a patient, young footballer, a fifth metatarsal pain, orthopedics, said it was an insufficiency fracture. He was a bit confused because they just said that off the back of a plain X-ray. Does that give you any more information to answer his previous question?
I'd say they probably got it wrong. I'd say it could be a fracture, but
yeah,
it could certainly be a fracture, but I wouldn't say it's an insufficiency fracture. I've never heard one in a teenager.
A terminology difference between orthopedics and perhaps there. Questions just coming from Andrea. How soon do you feel you can confirm osteomyelitis on X-ray? We have debates when we should re-X-ray when we suspect and treat, but not seen initially after 3 weeks, but need confirmation for continued. I've probably read that terribly big, but let's just go with that. How soon do you think you can confirm osteomyelitis on X-ray?
Well, it's a long way before you can confirm it, before you start to suspect it. I mean, you got to remember X-rays lag behind by about 2 weeks. So what you're looking at in the plain film is not, it's not exactly how it is on the day. I think if you've got a suspicion that there is osteomyelitis, you X-ray it. If there are signs consistent with OM, then you act upon that. If there's nothing on it, then a serial X-ray after another 2 weeks is probably the standard approach that we would take with our diabetic MDT. The radiologist would almost always say standard serial X-ray after another 2 weeks if you're not too sure.
Perfect.
I'm not sure if I've answered the question, but
I don't think I read the question very well, but it's actually quite a long sentence and I couldn't quite work out how to punctuate it, so it's probably my fault. But yeah, I'm sure that's fine. Question: when you request imaging, you often obviously have a high sort of index of suspicion for something already because you've taken the history, you've assessed the patient. You're not just, like as you said, you're not just saying let's have an X-ray to give us all the answers. Do you ever get really, really surprised with the result? Does it? I'm sure it correlates quite highly. What you expect is often what comes back. But can you think of a time when something really sort of threw you a curveball? You think, blimey, I can't believe how much this X-ray has now changed the direction I'm going to take this.
I think the prevalence of mid-foot osteoarthritis is really high. And for example, if someone comes in with a painful bunion, certainly if it's a significant deformity, you quite often see adjacent second MC joint away with it, and that's probably something that changes the plan, because you talk to someone potentially about a first met osteotomy or a first metatarsal cuneiform fusion, and in my practice these patients weight bear straight away on them. If they've got concurrent second MC joint OA, well, if you lock up the first MC joint, well, the second MC joint might have to work harder, and then that becomes symptomatic. So you've talked about a relatively straightforward recovery, and then now you're talking about having to fuse a midfoot joint that renders them non-weight-bearing for a further 2 months. And I would say that's probably the thing that creeps up most often, that's potentially unexpected, and then you come across it. But X-rays, as I said before, you request them normally for specific reasons. It's kind of unusual that something would creep up. Maybe a benign bone cyst that you might see, but it's not necessarily something you're going to act upon.
Mm-hmm. Yeah.
It's just a question here. Just a question here from Adnan about doing. It feeds on the radiation exposure, but would you go for a full lower body X-ray and a leg length discrepancy, which is an interesting one, because you're exposing radiation to a part of the body that you really do need to apply that ALARA principle.
Do you know what? I have no idea. I don't really do any MSK work, so I'm not. Ian would maybe be in a better position to say how how important that would be. I don't do any MSK
I
work.
would have think. I don't know about now, but in the past, chiropractors used to do that a lot. But again, it leads into that. What's the benefit versus the cost, and cost in terms of dollars and cost in terms of radiation exposure versus, is it going to change your treatment? I mean, you can determine leg length differences without x-rays. So it throws up a whole lot of issues there. But
I think times where it might be relevant, certainly in orthopedics, they will do it if they're going to perform a lengthening procedure. So they would want to know how much they need to lengthen. But I think, no, I've never done it. Certainly, I've never.
No, same. I never see these. Adnan mentioned there's a place on Harley Street that's doing this called the European Scanning Centre. I'm not familiar with them. Are you familiar with them?
Not familiar with it, no.
No, me neither. Who do you use in London for your X-rays? Do you send them to private hospitals? Do you use Vista Diagnostics or London Imaging Centre?
Well, the clinic I work in has an X-ray machine there, so.
Oh, you got it in house. Okay.
They've got it in house, yeah.
And do you receive? Could a podiatrist in London who's got their Emmer send them to you? Would you have your clinic happy to take people's money in that regard? Or?
I would imagine so. Because, like I said, these private hospitals will pretty much do anything to get money. So I need to ask, but I would be surprised if they rejected it. As long as it came, you might have to go and meet the managing team from the hospital and just say, listen, I need this. Is this a service that you can provide me? And like I said, they'll only bend over backwards to get your money.
Yeah.
Yeah, but it does raise the point about, I just noticed that just literally 200 metres from where I live, there's a new radiology clinic opening up. There's more and more of them opening up around here. But I suspect you're better off dealing with one that's used to dealing with podiatrists and the kind of information we're after, which in the example you're giving there would be a perfect one. That would be, they would be good to work with.
Yeah. It's like I said earlier, there's no point in sending someone for an X-ray if they're not going to take the X-rays the way you want them to be taken, because it's just a waste of everyone's time, really.
My approach to this, as you well know, has always been to, rather than be the person that's desperate to send for X-ray and come back to me, I always prefer to send to people like you. I mean, there is that debate, isn't there, in private practice? What should we do? I mean, should we skill ourselves up and get the Emmer and request them ourselves, or should we build relationships with the likes of yourself and refer to you and let you do all the hard work? What do you think as an overall profession? What do you think is most appropriate? I would the individual.
Yeah, well, I would love it if we were actually, like Craig said, that it was built into the undergrad system, because it's such a valuable tool, and it's a bit like local anaesthetic. I'm amazed at how many people don't use it just in regular practice, because it can help in so many different ways. And I think ultimately, for example, if I can give an example, not that you've done this, but if you were going to send me a patient who came to see you with a bunion, and you said, well, you need surgery, and you requested the X-rays, I'd be thinking, well, I'm not really sure why Ian's requesting, because what's he going to do with them, or is he requesting the right ones? I'm using that as an example. I know you've never done that, but
yeah, just to clarify.
Yeah, just to clarify. Yeah. So I think if you're going to request them, it needs to be something that you're going to act upon. So not necessarily a pre-operative X-ray. I'll do that just to save some time. It doesn't always work, to be quite frank. The intentions are good, but it doesn't always work. But I think certainly if people are trying to use it in MSK practice, would fire away, get the X-rays. And learn from them.
Yeah.
Because the more you do, like I said, the more you do and the more you look at, the better you get at it.
Yeah. Andrea's just asked a question. I suspect she has only joined the episode sort of halfway in, because I think we touched on this earlier. Essentially, she said, do you think it's essential to view the X-rays yourself? I order them regularly, but I can't view them, so I have to rely on the report, which can take some time to receive. I mean, I think we pretty much covered that about 15
it's essential.
I would start ordering the X-rays somewhere else, so you get the X-ray.
I would, yeah. Or speak to them and find out why you can't get them.
Yeah, but basically get eyes on that film.
Yeah, it's essential.
Yeah. Perfect. Any other questions coming, Craig? All of mine.
No,
I've ticked off my list.
No, that's pretty much all.
Right. Anything else? I know you teach this a lot. At sort of undergrad, postgrad, all levels to the surgical MSCs. Is there anything we haven't covered that, if you were doing a sort of a lecture on this, that you'd really want to impress upon the students? Is there anything else that you think we really need to sort of touch on before we wrap things up?
Yeah, I mean, I think as I've mentioned to you before, X-rays tell a story. So there's always something you can tell about this foot by looking at an X-ray before you've even seen the patient. And I think, if I just try and get into my little slides here, try and find an example of an X-ray which tells a bit of a story. There are always things that you can pick up. Sorry, bear with me for 2 seconds. Maybe I haven't got what I thought I had. Sorry about that. There are relationships between, for example, hallux valgus, second MTP joint overload. You know, you're looking at the thickness of the cortices of the metatarsals. You can tell potentially where an overloading site may be. But ultimately, if you're going to try and learn to look at X-rays, it's important to learn the terminology as well, and not just say, well, the bone there is wider than it is over there. Learn the correct terminology, and that way, when you potentially go to speak to a radiologist, you know, it sounds like you know what you're talking about, and they're much more likely to give you their time if they think that, you know, you're not just relying on them completely to give you all the answers. So terminology is a big thing, and it's something that people struggle with a lot. Well, I say they struggle a lot. The terminology that I hear is normally when we put our trainees under pressure and grill them to present an X-ray. So the pressure element maybe plays a bit of a factor there. But no, I think terminology is really, really important. And when I lecture to the undergrads, it's certainly an area that I focus on to make sure that they're describing X-rays in the correct manner.
So, any key papers in that regard? Any you know, someone says, okay, I really want to, after watching this, I want to bone up on my terminology, I want to get up to speed. Well, where do they go for this?
A radiology textbook, because it doesn't change. This is something that hasn't changed for how many years? So the terminology now is the same as what it was 50 years ago. So it's not really a case of needing to go out and find the most relevant papers or find the landmark papers, because this is all written down in black and white in the textbooks. It's very, very easy to come across and find them.
Perfect. So just pick up a book and you're halfway there.
Yeah, and you read through it, you know, and it's the same thing. It's the same descriptions time and time again. So it's not like you're learning a new language. It's the same words apply for many different X-rays, and it's just descriptors, really.
Great.
Now I can understand the need for plain X-rays in surgical cases, but given we've got ultrasound, MRI, all these advanced imaging, why bother with a plain X-ray?
Yeah, very good question.
I'm not saying we shouldn't, but just
well, certainly I think one of the most useful things about a plain X-ray is the fact that it's repeatable and you can use it as a landmark. Whereas if you have an ultrasound scan, well, I personally don't do any ultrasound, but if I get an ultrasound report, that's great. But if someone else did the scan, they might have reported it differently. Whereas I could send you, Craig, an X-ray from London to Australia, and we're looking at exactly the same thing. So it's essentially transferable. If you want to use it as a baseline, as long as it's weight bearing, you can use it to compare pre and post treatment, or, you know, monitor the progression of osteomyelitis or monitor the progression of a bone lesion. So I think they're great because they're quick and easy to do. They're very cheap, but more importantly, they're repeatable and they're excellent to use as baselines.
Yeah, sure. Now Sean's just come back and asked a question about hard versus soft X-rays and what are they used for.
Do you know what? I just expect an X-ray to be in the middle, and I like it to be in the middle. And if it's not, I'll send them back to get it redone. Hard X-rays I don't use them for absolutely anything. And occasionally I'll use soft X-rays to look electronically, because you can make an X-ray softer or harder. It's useful to look at periosteal reactions and things. But hard X-rays are just a bright white light shining in my face, and really no benefit to me at all. I'm not sure what they would be used for.
Yeah.
People that aren't familiar with hard versus soft, it's just like the contrast on your TV, is it?
So essentially, to go a little bit into the basics of how the X-ray works, you're looking at an X-ray plate, then the object is between the plate and the X-ray beam. So the harder a material, the more X-rays it absorbs. So metal, for example, absorbs all X-rays and it becomes out as bright white. Air absorbs very little, so it comes back as very dark grey or black. So if you have a hard X-ray, essentially it's had more X-rays fired at it, more has been absorbed, and it comes out as whiter, whereas a soft one will look almost like osteopenia, it will be everything will look fairly dark.
Okay.
But having said that, it's become a great lost art. I remember doing in the early 80s, a radiology course on using plain X-rays for soft tissues, and it was the guy that ran the course. His skills were just extraordinary, and it has become a lost art with plain X-rays to actually adjust all those features to look at things very, very differently. And it's become an even greater lost art, given we now have diagnostic ultrasound, MRI, and stuff like that. But I remember looking at some of these soft tissue X-rays in the foot in the 80s, and it was the guy behind it, and I've forgotten his name. He has a book on it, but it's well out of print now.
Yeah, I suppose the emergence of the more advanced techniques has probably meant that it's less necessary, I suppose. But my X-rays, generally speaking, they'll all come back the same way, and electronically you can always modify to make them brighter or darker, but I don't do a huge amount other than looking for maybe fractures or a periosteal reaction for osteomyelitis or something.
Perfect. Last question. I don't know if it's the lighting in your room. I know you've recently been on holiday, but I was under the impression that Irish men didn't suntan. You look quite bronzed there.
It's golden bronze, you're right, but it's also I'm also a bit red because my flat is about 45 degrees and I sweat like a pig, so there's probably an element of redness in there as well. I can assure you it's not pressure or an embarrassment.
I know, you're too cool for that. I've seen you in action. Craig, we are at...
that's probably a good time to finish on. We have had a lot of people on live during this episode watching, so that's good to see. For those that joined late, it will be on Facebook. Come back in about 10 minutes. We'll have it up on YouTube later on today. And for those who haven't noticed, it's now as a podcast on iTunes, Google Play, and Anchor FM. So that will be there later on today as well. So thanks, Ryan. It's been
pleasure.
Thanks, mate.
No problem.